Moderator of this session is Dr. Tarik-Bin-Abdur Rashid and Dr. Samia Tasneem. And the chairpersons are Professor D.S. Gambhir, Professor John Cornwell French, Dr. Imad Sheiban, Dr. Asaduzzaman. And the respected panelists are Colonel Dr. Abdul Malek, Dr. S.K. Hasan Mamun, Dr. Muklasur Rahman, and Dr. AHM Waliul Islam. I requested the chairpersons, moderator and panelists to take their seat.
Now I am requesting Dr. Asaduzzaman, please take over the charge.
Okay, thank you very much. Dear audience and respected speakers, panelists here, we are lucky enough that we have a very leading interventional cardiologist as a speaker of this today's session. Today there are 6 speakers: Professor D.S. Gambhir, Dr. Sanjay Karla, Professor Mamun Rashid, Professor Saidur Rahman Khan, Professor Arun Maske, and Dr. Imad Sheiban.
Right now it's...
First of all, may I request Professor D.S. Gambhir
I'm already
for
here.
present your topic.
Okay. Good morning, my friends. Well, as we have been seeing and we have been hearing that stenting or in other words, treatment of the left main coronary artery stenosis has always been a challenge. Challenge because if you create any complications, it is going to be life-threatening complications and you may lose a patient on the table, which is not acceptable in the present era. Over and above that, if you come across a patient who has got left main stenosis or left main occlusion and is presenting to you STEMI, that becomes still a bigger challenge. So my job is to highlight some of the features of a left main bifurcation treatment in a patient who presents with acute myocardial infarction. Well, if you go by incidence, involvement of the left main coronary artery, both in terms of stenosis and occlusion in STEMI, is very infrequent, 4 to 7% of the cases. But once it occurs, particularly acute occlusion, the mortality is very high and they often present with sudden cardiac death or out of hospital cardiac arrest. Well, ECG often shows anterolateral MI, and so therefore it is not very, it is often missed. The diagnosis of left main occlusion is often missed on the ECG. You go by it is anterior wall myocardial infarction, and the diagnosis comes only on angiography. But suspicion can come if the patient shows presence of ST segment depression in more than 1 millimeter in 8 or more leads, or if there is a ST elevation in AVR. So you can start suspecting left main occlusion. They often present with hypotension, cardiogenic shock, malignant ventricular arrhythmias, cardiac arrests. And the management is, of course, immediate medical stabilization, supportive therapy by means of intubation, ventilation, giving them a respiratory care, and then emergency revascularization, whether it's primary PCI or CABG. Primary PCI is certainly a preferred modality of treatment, particularly in situations like acute occlusion with TIMI flow less than 3, presence of cardiogenic shock, life-threatening cardiac arrhythmias, coexisting comorbidities where surgery takes a high chunk of mortality, availability of on-site interventional cardiologists and anesthetists. That's the most important factor because you cannot afford to lose time, and you need to have an experienced operator who has been performing left main PCI at least 20 to 25 per year. Now, this is our experience or my experience. We have done 613 patients by 2020. This does not include the data of last 1.5 years. And if you look at the type of intervention, 95% had elective intervention, but 5.3%, 33 out of these patients underwent an emergency intervention for left main coronary artery disease. And out of these 33, 14 were STEMI, 16 were non-STEMI, and 3 were iatrogenic dissections. So almost 4% of our population consisted of left main intervention due to STEMI. In these 14 patients, the presentation was hypotension in 8, out of which only 1 died. 3 patients presented with cardiogenic shock, two died and only one survived. Cardiac arrest, 2 patients came with cardiac arrest and both died. Patients with normal blood pressure, there was only 1 case survived, and overall 14 patients, the mortality was 35%. Now let me show you some interesting cases. This is the first case which we saw in 2006. This is an extensive interval MI with hypotension and came to us with malignant ventricular arrhythmias. This is a young man, 45 years, came in 2010. He had previously a stenting of the proximal LED in 2006, that means 4 years prior to his present presentation. He stopped all his medication for 3 weeks and he presented with anterior wall MI, blood pressure 70, ejection fraction 35%. When the patient was shifted to the coronary care unit, he immediately developed ventricular tachycardia, was cardioverted, put on ventilatory support, shifted to the cath lab. Fortunately, the lab was available with a blood pressure of 50 to 60 millimeters on inotropic support and tachycardia with a heart rate of 140. And this was his angiogram. You can see here that there is a total occlusion of the left main and there is a stent which is lying in the LED. Well, what we did was the first thing was there is a thrombotic occlusion which we analyzed and we start giving him Apiximab. There was some for a second issue whether we should put him on IIBP or not, but we thought we should first start poking the left main and restore the flow. So we put a guide wire was placed in the circumflex. It went, on its own it went into circumflex. We did some thrombosuction from left main and single pass led to restoration of flow in the circumflex. You can see TIMI3 flow in the circumflex and TIMI1 flow in the LED. So following this, we deployed a stent DES in the circumflex ostium. Why? Because after 5 minutes, the circumflex again started occluding and the patient BP again fell down. So we thought we should first take care of the circumflex. So we deployed a stent in the circumflex, which looked reasonably okay, and by now the BP had stabilized. So it gave us some breathing time to now poke into the LED. So we could manipulate the wire into the LED, and this is the result after deployment of a second DES from LMCA to LED, overlapping the LCX stent, and then we did a kissing balloon dilatation. So restoration of TIMI3 flow was obtained. This is the final result. The patient was uneventful after being taken out of the cath lab. He was extubated after 48 hours. Hemodynamically, he was stable for the next 2 days, discharged on day 5, and follow-up angiogram after 4 weeks. This was the follow-up angiogram after 4 weeks, showed that both the vessels were very patent. The patient was on follow-up for almost 6 years after that, and he was doing very well. This is a second case, again a left main bifurcation stenting, but not a total occlusion, presented with anterior wall MI with hypotension. 52 years old young man, ejection fraction 30%. You can see here that left main has got a distal stenosis. There is a total occlusion of the LED, and LCX has got a significant stenosis at its origin, and then there is a disease at the origin of the obtuse marginal branch. So since the patient was becoming hypotensive, so immediately we passed 2 wires, and having done that, we used the SKS technique. This was again very, I think in almost about 2009 or 10. So we used SKS technique, which was very popular at that time. 2 stents were taken down, both inflated at the same time, and the result was excellent. This is the final result. So again, this patient did very well and was discharged on day 4. The third patient is a patient who presented with acute posterolateral MI. Now, where we were a little baffled by the angiogram. This patient was 63 years with acute chest pain, was stable. Hemodynamically, he was stable with a blood pressure 110. He had only ST elevation in lead 1, AVL, V5, V6. So we thought he may be having only circumflex stenosis. But this was his angiogram. Now, you can see that left main distally is having mild disease, but LAD osteoproximal is a very moderate disease, but the tightest stenosis is in the original circumflex and the obtuse marginal branch. So we first did a stenting of the LCX. You can see from the ostium, a stent was placed with wiring of all the 3 major branches, and then following this, we stented the obtuse marginal branch going from the stent in the circumflex using the tap technique and then followed up by a kissing balloon dilatation. Following this, we did the stenting of the LED from left main to LED using a reverse T technique, and then this is the final result. So here we had a trifurcation stenting in a patient with acute posterolateral MI. And lastly, a patient who came with cardiogenic shock. This is a young man, was having chest pain for the last about 8 to 10 hours, came to us with a blood pressure 70, oxygen saturation 77, ECG showed anterior wall MI with bifascicular block with ST elevation in lead AVR, ejection fraction of only 20%. The patient was very sick, inotropes were started, intubated, pharmacotherapy was started, and high-risk consent was obtained, IABP was placed in the lab. So this was his angiogram. Right coronary artery was okay, young man, but you can see that there is a ruptured plaque with a thrombus in the left main with some flow in the, maintained in the circ OM, but LED is 100% occluded. We had no, we did not lose any time in cannulating this LED, but since we were very concerned about this OM also, because if we lose this OM, the patient would die on the table. So we did a mini crush here. I took 2 stents, one in the LED, that went to LED, and the other one was in the circumflex origin. And then did a kissing balloon inflation. All this with a blood pressure of 80, 90 and augmented pressure about 120 on IABP. So TME2 plus flow could be restored. But unfortunately, the patient was stable, conscious on day 2 with a augmented pressure of 135. ECG showed a partial resolution of ST segment. Day 3, patient developed high-grade fever, no urine output, blood biochemistry showed parameters suggestive of septicemia, and the patient expired with multi-organ failure. So, friends, what is the role of IABP? Arbitrary, ambiguous, and controversial. ACG-HA say it's a class 1 indication, particularly if a patient is in cardiogenic shock and unresponsive to pharmacotherapy. And a meta-analysis of 16 studies have shown that there is a significant reduction in mortality. There is no significant benefit if cardiogenic shock has been pre-existing for more than 12 hours with oliguria. Now, this is another study of 30-day all-cause mortality, which is an average of 13 studies. You can see here the difference between patients who come with cardiogenic shock compared to those who do not have cardiogenic shock. The overall mortality at 30 days is 5 times higher in patients who present with cardiogenic shock secondary to left main occlusion and anterior wall myocardial infarction, and this figure is statistically significant, 10% versus 56%. And another study which shows a long-term outcome for unprotected LMCA when they compare it with non-LMCA shock. So you see that in hospital mortality is again much higher in patients who got a LMCA as the cause of cardiogenic shock. And this is statistically significant as compared to non-LMCA. 30-day outcome, 1-year outcome, and long-term outcomes are all inferior in patients who have got a shock secondary to isolated LMCA occlusion compared to those who do not have LMCA occlusion. So, in conclusion, what is the take-home message? Hemodynamic and electrical instability are the most important challenges in such cases. A speedy action is the most crucial factor in preventing sudden collapse. Cases like these must be done with on-site supportive anesthetists. IABP must be inserted if required. Strategy of stenting should be decided only after establishing the flow in both the vessels. Liberal use of GP2B3A, which of course may not be required in the present era because of highly potent antiplatelets of agent being available. PCI strategy is to be kept as simple as possible. Bifurcation may require a 2-stent strategy, and do not hesitate to use a 2-stent strategy. Rotablation may be required rarely in such cases. With that, I thank you very much.
Thank you very much. Thank you for a brilliant presentation, and I hope, I think that these are the worst cases of your cath lab, which showed you in our presentations, and I hope we will be encouraged and will be mentally boosted up from your presentations, I think so.
Thank you.
Our next presenter is Dr. Sanjak Karla. He will talk on how to deal with calcified lesion.
I don't think the laser is going to help much actually, because I'm going to have to point at the screen on the back. So good morning everyone. Thank you very much for joining us again. Over the next 12 or so minutes, we'll do part 2 of the talk that we started yesterday. Yesterday we learned how to look at calcium with a very careful quantitative eye. right? We don't look at calcium now as it's on the angiogram or it's off the angiogram. We look at it much closer than that now, where if there's an arc over 270 degrees of calcium that is more than 5 millimeters long, that gets a point. That there is the presence of a calcified nodule, that gets a point. If there is reverberations, natural reverberations that are greater than 90 degrees, right? So there's more than an arc of reverberation, that does not get a point. If there are no reverberations, you get a point, right? So reverberations means thinner calcium, okay? And then the length of the lesion and the size of the vessel get a point. So if your vessel is greater than 3.5 millimeters, no point. If it's less than 3.5 millimeters, you get a point. And if you have any more than 1.7 points, so for closest rounding, if you have any more than 1 point, you're almost certainly going to have to modify the calcium to some degree to get the result you're looking for. So if I can get my slides brought up onto the screen, there we go. So let's take part 2 now and start us with a question to our learned panel. We have a number of very learned panel members here. We have many experienced interventionalists in the crowd. And my question to you is, how do you know when an OPN balloon is going to work? What is it that makes you decide you're going to pick that? How do you know a Wolverine is going to work? What makes you, Dr. Maskey, I mean, if you're going to pick an NC balloon to crack a lesion, when are you going to pick an NC versus when are you going to pick a Wolverine? And what makes the difference and how? You don't have to answer here, but the question is a real question that we try to answer every single day. We do this in the midst of our practice every single day, but with what structure? And so my goal over the next 12 minutes is to crystallize that structure a little bit and give you my approach. It's one approach, but it seems to work for me. These are my disclosures. So these are the current concepts in coronary calcium management. There's this algorithm, which is got all kinds of crosses and twists. There's this one, which has got even more. It starts to make your head hurt. And then there's this algorithm that came out by Optima, which looks like a map from the London Tube. It's too complicated. There's too many decision points. There's too much to look at here when you're trying to make careful decisions in the course of managing a complex case. So we need to make this a little bit simpler. This is the algorithm that we put up yesterday. If you have angiographic calcium, then think of your algorithm or your score around whether or not this calcium is going to yield. For that, you need to use intervascular imaging. If you have no angiographic calcium, even though there may be some there, it's probably thin, balloon it and stent it and go. So if you now have angiographic calcium and you've imaged it, let's say you use IVUS and you have the presence of reverberation, so the calcium's less than 0.5 millimeters thick, but there's an arc of over 270 millimeters, right? Or 270 degrees, so you have 2 points. How are you going to modify this? Are you going to use a cutting balloon or an Opn balloon? Are you going to Rodi it? Are you going to use lithotripsy? So let's try to crystallize that and try to make some decisions, make some decision points around how we make these things clearer. These are the open questions that we ask ourselves about these therapies. Which lesions take what balloon? Long lesion, short lesion, fat lesion, small lesion? I mean, you know, it sounds a little bit like a children's song. Which one do you use atherectomy on? Long, short, heavily calcified, moderately calcified? What about safety and pressure advice? Who's comfortable taking an OPN balloon to 35 atmospheres in every lesion? You know, what if this is a 90-year-old woman and you're worried that it's an aneurysmal segment and you're going to tear the artery? What about IVL? Is it going to pass? Can you get it to the site? Is it worth cracking the $3,200 because you think that even though it's going to give you great results, you can actually get it there? How do you line up the emitters to get the best result? How many pulses do you put on every lesion? Do you prep it first? Do you prep it with totally contrast? What's the concentration you use? All of these things are open questions. And of course, the other big question, of course, in our market here is cost, right? Because we've got to consider the various things that are necessary to deliver therapy in these challenging patients. So let's start with an OPN balloon. This is effectively a Kevlar-coated, double-layered balloon that allows ultra-high pressure inflation. The misnomer is that if you have an underexpanded lesion, you take a bigger balloon. You could not be more wrong, because the area of underexpansion is still touching the walls. What you do is either take a smaller balloon or you take an OPN balloon at 1-to-1 pressure and you crank the pressure high, because it's the pressure that's going to create your axial and longitudinal cracks in the calcium that will allow your balloon to expand. So let's take a look at this inferior STEMI for a second, okay? That's an ugly and calcific lesion. And in this case, we ROTA'd it because nothing would go. The tip-off, by the way, to whether or not you're likely going to need ROTA is if you put your wire across and you can feel grit in the wire is captured by the calcific lesion, don't bother with anything else. Good luck. OAS is not going to pass, IVL is not going to pass, you're going to have to atherectomize it and then use a combination technology of some sort. So we ROTA'd this, and then we put a 20 atmosphere 3.5 NC balloon distally, and that looked like it expanded. And so we put in a stent, but you can see here now, distally, there is an area of underexpansion there. So how am I going to fix this problem now? Look at the stent boost, right? It's clearly underexpanded at the edges. But fear not, we IVUSed this. And what do you see? You see a ring of calcium, but you see reverberation artifact in 2 quadrants. That means this calcium is thin. And that is where an OPN balloon at 35 atmospheres comes in. So circumferential calcification with thin calcium is what gives you a good result with pure high pressure. So going back to our algorithm, we can think about how to fit this tool into the way we treat calcified lesions. I wasn't worried because I know that based on contemporary evidence, high pressure will yield calcium that is less than 0.67 millimeters thick. Okay, you can get that measurement. So if you don't have reverb, it's better to safely assume that it's more than 0.67. If you have OCT, you can measure that out. But if it's less than 0.67 millimeters thick, or your arc is about 220, you can crack that with a high pressure balloon. Just do it and move on. That's how we consider OPN balloon efficacy. It's a function of calcium arc and calcium thickness. So going back to our algorithm now, let's develop this out. If you have a stent or if you have a calcific lesion with relatively thin calcium and your stent is underexpanded, this is where I use my OPN balloon. I don't use it up front because most of the time if I've imaged and I've got thin calcium, I can crack it with a high pressure NC balloon. But if I've got a stent in place or I've got thicker calcium in one place and thinner calcium in another, there's your OPN balloon. Okay? And you take it up 0.75 to 1:1 size and you go to town. You'll be fine because you have an image to tell you that the vessel's not too small for that balloon. Now let's move towards a cutting balloon. So these are true NC balloons, right? They are NC emerge balloons that can, everybody from Boston Scientific can plug their ears, that can go up to much higher pressures than they tell you they can. I've taken these balloons up to 24, 26, 28 atmospheres in live cases or not live cases. Many times they work just fine because it's a real NC balloon. They have triangular athertomes on the outside. So what you're doing by putting these things up to high pressures, and the iteration on the flextome was tighter packing and the fact that the flextomes, athertomes were squares. These are triangles. Is when you impart force on a triangular athertome, a smaller unit, you're imparting more force per unit area. So this is make a crack, okay? This device is to make a crack. That's what you're really trying to achieve. You're not trying to obliterate the calcium. You're trying to make a crack in at least 2 places so that you don't get a fulcrum. You can actually allow both halves of the vessel to expand when you put the stent in. So when we look at the actual data around cutting balloons, and you look at cutting balloon plus stenting versus PTCA plus stenting, when it's IVUS guided or when it's angio guided, both ways what you find is that you're going to get better results when you break calcium. Okay, the key is the calcium crack. So let's look at this 61-year-old with a long LAD lesion. Once again, nothing would go, so we ROTA'd it. Then we put a 4.0 NC balloon, and I took this to 28 atmospheres and went back and forth and back and forth and back and forth, and it laughed at me. But then, after I had imaged, I recognized that there was a physical area of calcification that was nodular, but the rest of the calcium in that arc was thin. And because I recognized that, I was comfortable taking a Wolverine cutting balloon, taking that up. In this case, I took it to 22 atmospheres, got it fully expansive. And once again, if you look here, you'll see that there's a nodule on one side, but now you've got reverb that you're going to see on the IVUS there. See nodule there, and reverb all around the various cracks in the calcium. Here, 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 right? So with reverb, once again, your thickness is not particularly high. And even though you got a point for the nodule, the other areas with reverberation are going to crack with a cutting balloon, and you get a very nice result. And you can combine all kinds of these strategies, ROTA cut, ROTA plus IVL to give you rotatripsy. Whatever you need is based on the amount and morphology of calcium you're dealing with. So predictors of fracture of calcium with a cutting balloon are a calcium angle less than 200 degrees, so just over 3 quadrants, and a calcium thickness of less than 0.5 millimeters. So 3 quadrants of calcium, even if one side is a nodule, 3 quadrants of calcium that is thin, and you'll get it with your cutting balloon. Okay? So going back to our algorithm, cutting for thinner calcium, stent in balloon. Or if you have suboptimal crack following rota or following orbital atherectomy, but you have demonstrably thin calcium in those places, this is your friend. This is when you use your cutting balloon. Now what about shockwave? This is cool. This is my friend Lorenzo Azzolini. You'll see him put his fingers on this thing, put his fingers on the emitter, and it doesn't actually affect distensible tissue, right? These are impulses of sound going into soft distensible tissue. So distensible tissue doesn't crack. Calcium cracks because it doesn't bend, right? That's how sound waves work. So when you look at a pooled analysis, you can look at the Disrupt-CAD 3 trial, which had very good outcomes and a lot of good growth on the acute lumen to allow stent placement. Even when you look at multiple trials over the Disrupt-CAD series, what you see is that pretty consistently you're getting good procedural success, right? This device does work. The problem is it's hideously expensive and it doesn't get to where you want to put it half the time. So how do you train your eye, or how do you change your algorithm to be able to use this device appropriately? So what we look at is once again, the amount and thickness of the calcium that you're using. So this is somebody who had severe thick calcium who was on Impella support. And this is a major determinant of whether or not IVL is a good choice. If you have individuals where your hemodynamics are concerning, right? If you're a little concerned about doing rota or you don't have access to an Impella, this might be a place where you'll fit IVL into your algorithm because the learning curve is 0, it's pretty safe. And if you can get it to the site, so that's key, if you can get it to the site, you're unlikely to cause hemodynamic compromise with short 10-second inflations. Right? So that fits into your algorithm there, right? And what we did here, once again, is we opened the IVL, we tried to put it in and it laughed at us. So we wrote at it, and then we put it in. And we got this beautiful fracture result. So you've got all kinds of cracks in the calcium in the LAD, but then if you look back at the proximal LAD here, you'll put your eyes on the ring that comes up, and I'm just going to fast forward this through in the interest of time. There. You've got an ugly calcific ring without reverb across more than just this tiny segment in the sort of 1 to 3 o'clock range, right? So this needs more. So you can upsize the rotoburr, but in this case, the hemodynamics were already an issue. So we used 60 pulses of a 3.5 millimeter shockwave, got a great result with a ton of crack, and then we've got a minimal stent area of like 12, right? Which is what we're going for. So in the Bangladeshi context, virtually no learning curve, useful on thick calcium, useful with patients with low EF. What are the downsides? It's expensive, it costs a lot, it's difficult to raise the money, it's expensive, and it's expensive, right? And there are some open questions about how to deliver it and you know, working out where to put pulse emitters and how to prep the balloon. So this is a very useful therapy. It is an extremely effective therapy, but it's a matter of us targeting it to the right patient at the right time. Okay, and so that's what this might look like. That's what this looks like in my practice, where if I've stented it and I've got underexpansion due to calcium, this is an IVL patient. If I've got under treatment with my first pass of rota, this is an IVL patient. If I've got a bad EF where I don't want to rota, this is an IVL patient. If I've OES'd it, if I've done orbital atherectomy and I've got cracks in some places, but I still have a core out of calcium that's not thin in all 4 quadrants because I remember I want more than 1 crack, this is an IVL patient, right? So the point of this is to get us away from, let's try this device and see if it'll work. That's not good enough. It's 2022. We're better than that. What we now need to get to is, let's target our tool. Our square peg goes into a square hole. Our round peg goes into a round hole. And in that regard, each of these tools, IVL, cutting balloon, OPN balloons, they all have their own utility targets, right? And so you use those utility targets, those algorithms, to be able to define what it is that you're trying to achieve, which is multiple cracks in the calcium that you're treating so that you can get good stent expansion. So your take-home points. Image, 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 image. It does not make sense to do complex cases with one hand tied behind your back. Has anybody ever used the 5th generation drug-eluting stent? Have we seen the fifth generation drug-eluting stent? I mean, we're pretty keen on Synergy or Resolute Onyx or Xiant Sierra or Alpine or SkyPoint or all these really good stents. What about the fifth generation drug-eluting stent? There isn't one. It's called Intervascular Imaging. It has independently reduced heart outcomes by 40%. It is nuts to take all of these other devices and not learn how to use imaging, because that's going to be the biggest change in your outcome. Once you've imaged, use the specific points that we've discussed to be able to target what tool you use to the therapy that you're trying to provide. Recognize that thinner calcium responds to pressure, whether that's OPN because of a larger arc or a cutting balloon because of a point pressure to create multiple cracks at the same time. It responds to pressure. And then in thicker calcium, in longer lesions with vessel disparity, in bad EFs, IVL may be a good choice, but be careful, you need to get it to its site. And so the likelihood is you will end up using it in combination with a rotablation therapy or another therapy that'll modify calcium to allow you to deliver. If you have a nice lumen there with circumferential concentric calcium that's thick, your IVL can become a very reasonable choice as well. Thanks very much for your time and attention.
Sanjog, thank you for
very
your
much.
presentation. I have one query actually. We all know every dog has its own tail and every device has own indication. Definitely you rightly said it very well. But what do you mean by fifth generation stent? Actually, we are used to use up to third generation stent available in our country.
So when I said fifth generation stent, I was using it as a joke. There is no fifth generation stent. Right. It's called IVUS. It's called OCT, right? So that's the big outcome differentiator. And the answer to where to use that fifth generation magic bullet is as many times as you can. Certainly with the 9 randomized trials that are out there and the 3 or 4 large multinational registries, it is malpractice to do complex intervention, so left mains, bifurcations, chronic total occlusions, highly calcified vessels without the use of intervascular imaging. But in my practice, and I realize there are contextual issues here with the market, in my practice, I know I'm not doing as good a job when I don't use the imaging. And that's why 90% of my cases are imaging guided, because what makes me sleep at night is to feel like I did a good job, right? That's for me. And so I sleep at night because I know that I did a good job. If I don't sleep at night. That's not worth it to me.
So it's look like industrial revolution, like 4th generation.
What's that?
4th generation industrial revolution.
Yes.
Like artificial intelligence. We should use more tools to optimize our procedures.
It's using what you need to use to get the job done.
Okay, thank you very much.
Thank you, Dr. Kabra, for your brilliant experience. I'd like to know what is your experience regarding the safety issue of Opn Balloon versus IV?
So the major concerns, the question was, what is your experience with OPN for safety versus IVL?
Yes.
Generally speaking, OPN, because of its dual layer technology, is a very safe high pressure balloon. You do need a specialized indeflator to be able to indeflate it, but as you probably know. But the most important things with OPN balloon preparation is preparation. Do not let a single drop of air inside that balloon, because when balloons rupture, and OPN, the inner layer may toast, but the outer layer won't. If you get an OPN balloon rupture at those pressures and you have any air inside that balloon, that air comes out like a needle, because the density difference between air and contrast results in the air evacuation through a point at a very rapid rate. That's how you get your perforations. IVL is a low pressure, high compliance balloon. Right? So ruptures with IVL are those things that are very difficult to predict. It's just jagged points of calcium that you don't know, you can't see that, right? So you're safest with IVL to keep your low pressure inflation and then use the pulses to be able to actually get the result that you want. Once you've delivered several sets of pulses, you can start taking your balloon up to 6 atmospheres to maximize the vessel compliance and then take it down. The other issue with IVL that I have observed, and 2 out of the cases that I've done, is no reflow. But I missed something on the imaging when I did that. That's on me, because when I looked at that calcific lesion, there was a necrotic core behind it. Okay, there was a high lipidic plaque behind it, and so in that scenario, what I probably should have done was atherectomized it. Hindsight's 20/20, right? I may have had to do both. This particular patient in whom I had no reflow, had an ejection fraction of 10%, Lariche syndrome, no arm vessels, 1 leg vessel, and that had a balloon pump and my sheath in it. right? So I'm not going to be, taking chances with atherectomy in that scenario. It's not a safe thing to do, right? So, and the predictability of no reflow, it hasn't been described that often, so I don't think I have a good answer for you there.
Have you ever experienced for rupture balloon in opioid or IVL balloon?
Have I ever experienced an IVL rupture?
Rupture?
Yes.
Yes.
Yes, but that once again, the IVL rupture was not because of a pressure problem or a balloon construction problem. It was because calcium sometimes is a jagged edge and you just get bad luck, right? It's rare, right? But when how many times have you seen a rotablator cause no reflow? Geez, it happens all the time. Let's say you do everything perfectly.
So
do you still get no reflow?
Situation,
sure.
your
Right?
recommendation should we go for first NC balloon, then go for Opn balloon, then go for IVL?
No, my suggestion is you image first and then
Definitely,
decide if your calcium is thick or thin. If it's thick and it's deep, so it's not surface calcium, go to IVL. If it's thick and there's surface calcium, rota it first. And then if there's a need to crack further, go to IVL. If there's thin calcium, go to either NC if it's less than 3 quadrants, OPN if it's more than 3 quadrants and there are sections of it that don't have reverb, or a cutting balloon if it's more than 3 quadrants and there are all of the sections do have reverb.
But if you have calcium nodules, then what should you do?
Rota.
Rota.
Yeah. Rota or IVL. So calcium nodules for what it's worth, intercoronary calcium comes in multiple flavors, right? There are the deep circular hard nodules
we are running short
deep.
of time.
Yeah. Okay. Thank you. I'll be happy to answer those questions offline.
Thank you again for Dr. Shangjaya Karla for dealing with the calcified lesions. So now may I call Professor MD Mamun Rashid Caesar. He will talk on Cto PCI, integrated approach, case-based discussion.
Respected Chairperson, dignified panelists and audience, Assalamu alaikum and very good morning. Today, my topic is Cto PCI, integrated approach, case-based discussion. All of you know that the Cto is one of the most challenging part of the intervention and cardiology. More than 50% have oil preserved reduction and only 8 to 15% are undergone PCI. Every interventionist dreams of expertise in Cto PCI, but it is the last niche in the field of interventional cardiology. Cto Club defines Cto as the presence of TIMI-0 flow within an occluded arterial segment equal or more than 99% of stenosis, more than 3 months of durations. Why Cto intervention is necessary? Several trials shows the Cto PCI decrease the angina, increase LV systolic function, increase exercise capacity, and decrease the consequence of future acute coronary syndrome, decrease arrhythmia, decrease CABG, and decrease long-term mortality in those with a successful recanalization. Here, the ST elevation in my patient here shows that Cto shows increased mortality in 30 days and 5 years interval, and shows that LV ejection fraction improvement occurs, and successful Cto PCI improves 10 years survival rate, and it decreases the MACE rate, and it decreases the need of CABG. Now, I just discuss the basic things of the Cto crossing techniques. Before discussion the Cto crossing techniques, we at first evaluate the clinical and imaging condition of the patient. If the proximal cap ambiguity, duration of the occultation, lesion length, quality of distal vessels, that means tortuosity or bending, collaterals, calcification, etc. Just here we show the basic things to steps of Cto crossing. That is, here the piercing of the proximal cap is the first step, then traversing the length of the Cto proper, then piercing the distal cap. And Cto crossing technique has two strategies. There is antegrade and retrograde. What we do is now there is a hybrid algorithm we follow. There is a hybrid algorithm, there is dual catheter angiography was done, and if the proximal cap is clear and the good distal target and no appropriate interventional corticosteroids, then we choose the antegrade technique. And wire escalation was taken, and if failed or the lesion length is more than 20 millimeter, then antegrade dissection re-entry technique can be tried. And if it is failed, then retrograde dissection re-entry technique was tried. Here the 4 approach was taken for the CTO crossing, that is single wire manipulation, parallel wire technique, seesaw technique, IVAS guided wiring. Single wire technique, there is at first the workhorse wire is tried, and there is hydrophilic wire, then intermediate wire, then stiff wire, and again there is intermediate wire and stiff wire. After crossing the lesions, normal workhorse wires changed. This is anti-gate technique. These are the guide wire which are used, that is slippery wire for the fielder X3 whisper, intermediate wire Miracle 3, Gaia 1, stiff wire Miracle 9, 12, Gaia 2, 3, and stiff wire with taper tip Conquest Pro 9, 12. Here, which wire to use when? That's here shows that in case of channel communication is there, then only hydrophilic wire, whisper X3 R and whisper wire can be tried, and where the with lesion CTO lesions have the stump, then here Gaia fast can be tried and pilot 50, and in case of the without stump there is a hard plug. In this case that is Gaia 2nd, Gaia 3rd and Miracle 9 and 12, and if the severe calcification, then Conquest Pro 9, 12 can be tried. Parallel wire training, there at first the first wire goes to the false lumen, then second wire is taken, and again patching between the B and A, and which enters the true lumen. Seesaw wire method with double support catheters, it's one kind of variation of the parallel wire technique. Here the 2 microcatheter is used, that is the different. And IVAS guided wiring, checking for the CTO entry, checking for position of wire, examination of the subintimate space, penetration from subintimate space to true lumen. Here the basic technique which is appeared in case of the CTO total occlusion as the one of there is the drilling technique, and is the penetrating technique, and is the sliding technique. In case of drilling strategy, it implies that gradual step up of the wire's stiffness according to the lesion complexity, relying on visual as well as tactile feedback information from the wire tip. The wire is rotated to and fro with the left hand, while the right hand is used for rotation 90 to 180 degree. In case of penetrating strategy, it implies that direct pressure at a point in order to cross into the distal true lumen with limited rotation of 45 to 90 degree, the wire is stiffer, usually Miracle 12 or Conquest Pro 912, taper stiff wire is used in this strategy. Sliding strategy, it means the slide of a hydrophilic wire, usually it's used in case of the where the lesion have the microchannels, subtotal occlusion or in stent occlusion. When to quit, every intervention should know the when to quit in the CTO PSI. When technical success is achieved, major complication and operational limit reached, there is patient tolerance, fluoro time, contrast volume, procedural time. Now I want to discuss some cases. There is first case, patient 52 years, non-diabetic, non-hypertensive, history of non-STMI, 4 months back. CAG shows LED 100% occlusion. There is an RCA L6 normal, and there is a retrograde from the RCA. At first we tried with the stiffer wire, pilot 150, and failed. Then we take the support of the microcatheter and cross the lesion. Here one technique is used that we push the microcatheter and visualize the distal lumen, and then we completed the wiring and the predilatation, and after predilation the stent deployment was done, and it is the final result. In second case, Mr. X, 56 years male, diagnosed as a case of the chronic coronary syndrome, hypertension and diabetes mellitus, history of non-STMI 6 months back. ECG shows T inversion BU 1 to 6 and echo normal and ejection fraction 56%. Here contralateral view shows there is a 100% occlusion in the LED, and we tried to negotiate the CTO lesion, and we try at first with the pilot 150, but pilot 150 it goes to the false lumen. Then we again try the Gaia 3, and we after several attempts, we enter the true lumen. This is the true lumen. Then we try to dilate the balloon 1.5 balloon, but unfortunately 1.5 balloon cannot cross the CTO lesion. Then we take the guide extension catheter support, that is Godzilla, but with the support of the Godzilla we cannot cross the lesion. Then we decided to do the rotablator, and we use the rotablator, and after rotablator we were crossing the lesions and predilation done, and proximal stenting deployment was done, and this is the final result. Case 3, patient with old MI inferior, CAG shows LADL6 normal, RCA shows 100% lesions in the distal segment. And here the problem is that we at first do not done the contralateral double catheter denosis, and the wire goes to the false lumen, and after taking the contralateral view we successfully cross the lesion in the true lumen. Here the predilation was done, and after post dilatation this is the final result. The case 4, patient with MI eccentric anterior, coronary angiogram shows LAD 100% occlusion, and LCX and RCA normal with retrograde to the LAD. And with the help of the balloon, 1.5 balloon and the pilot 150 wire, we crossed the lesion and predilation was done, and deployment of the stent was done, and this is the final result. Take home message: CTO-PCI is a challenging technique which should be done in a careful and organized fashion. Clear-cut indication and proper case selection is needed for CTO-PCI success. Avoid ad hoc procedure, planning is crucial. Always try to do double puncture, introduce double catheter and visualize distal vessel for CTO intervention. Avoid preventable complications like contrast and radiation. Preparation for complication combat, there is perforation, tamponade, and with equipment should be in hand, there is covered stent. Patience, proper planning, appropriate hardware selection, and some special technique adoption, proper training and experience, preferably long learning curve as the mainstay of CTO success. Predefined limits for stopping, never lose hope, keep patient safety first. Keywords for success of CTO: believe in yourself. That is, at the last we can be successful for CTO PCI, and perseverance. If at first you do not succeed, try again. Thank you. Thank you for patient hearing.
Thank you very much. Thank you for excellent talk on CTO PCI. May I request Professor Saidur Rahman Khan for his speech. He will talk on shock therapy, case-based discussion. Actually, the shock therapy in our country, I think, is a very new era, and he will talk on shock therapy, and he will show us many of his cases, so we'll learn from him. Thank you.
What I shared just yesterday and today, and both days actually we are talking about more and more about the bifurcation and the calcium, because these two are the talk of the planet, talk of the town and everywhere. So every time we talk that one and actually becomes bored sometimes. Like Dr. Carla has already talked about beautifully about the 3 modalities or balloon-based techniques for calcium. So I'm going to highlight especially on the shock therapy also. Just before starting, if you see these 3 pictures here, so you can understand that to understand the calcium and how it is producing in the coronaries, it's like I don't like to recollect even that these things which I have read in pathologies or pathophysiologies. So this complexity means the calcium itself is very much complex, and the same way to treat that one in the coronaries is also very, very much complex. And arbitrarily, calcium is like a ghost, and if you face a ghost, sometimes you need a magic wand, like shock therapy. So that's why my discussion is like this, especially in a practical way. The calcium is a disastrous recipe, no doubt about it. Proper diagnosis of severity is a very much important thing before touching that one. And lots of algorithms so far with the advent of lots of armamentarium. If we have so far 3 orthodox imaging tools to understand the calcium, because that is the most important thing to treat a calcium. So like angiography, IVUS and OCTs. But among them, you see the angiography itself can detect the mild calcium only in 38% case, and if it is severe, only 85% case. That means 15% case can be missed even by angiogram. OCT obviously is relatively better than IVUS, except in the ostial left main or somewhere, and also by OCT based this Fujinos severity like 180 degree arc, more than 180 point, more than 0.5 millimeter thickness and more than 5 millimeter length is important. If the modalities we see, it is in great evolution. And that's why, and the trials which are happening not that much, because actually by few years, for last few years, the calcium has been in the concentrations. So starting back in 2013, the Rotaxis trial, then Orbit 2, and then Prepare Calc, Disrupt CAD 1, 2 and 3. 3 is the latest one with a 1-year outcome, and finally the Crunch registry. So these are all about the calcium, and the calcium trials not that much big like in bifurcations. And the weapons, you know, that balloon based weapons like NC scoring, cutting, OPN, chocolate PTC, which is not in this part of the planet but beyond the Atlantic, it is available. And in device based, you can see the rotablation, ELCA or laser, and the orbital atherectomy. And in balloon based technique, we have got, especially in this country, the newer one is the IVL. Which weapon and when? You know, lots of algorithms. I like this algorithm a little bit like AMASA, like assess, you modify, then you will grip the assess again and then make the stands. And you see in the red line, the shock wave is possible, and you can give there when you have a superficial calcium and also you have a deep calcium. And that's why how shock works is actually obviously totally an applied physics things. I can't understand sometimes, like with squeezing, then it causes cavitation and then fatigue and ultimately spallation, and ultimately it cracks the calcium. So let's see a case, a 70 years old post CAVG case. So ultimately you know that severe calcium is predicted there, and it's 2 grafts, Lima 2LD and SVG2M is patent. But what about that unprotected RCA, which is almost subtotally occluded, but even angiographically you can just appreciate that how much calcium it is there in the beach. So too much to handle even angiographically. But the deep and superficial calcium you can see here, and this dust in the old case is what to do. First tux to wear, not to be that easy. Ballooning by modifiable balloon as much as it permits, of course, or you can go upfront rotablation by taking the rotawire initially. So that is also one option it can be. And imaging by OCT, initially it cannot be possible, and then after ballooning you can take the IVUS catheter or the OCT catheter, and you can assess the severity of what you are seeing in the angiography, how much the superficial calcium is. And then to choose the next armamentarium, whether the rotablation or the IVL or the mixture of both, the rotablation plus IVL. So what we have done is 70 plus years old and very much fragile. I was trying to avoid the rotablation if it is possible, and if I can see by IVUS or OCT that how much calcium or how much it can be dealt with. So NC and scoring balloons with upscalation of the balloons, how much you can to test the might of the calcium didn't work that much. You can see the dog boning effect there even with the ballooning. And then IVUS did it. It is confusing. It has confirmed that some napkin ring calciums are there especially in the disease segment, which has not been cracked by the MB. And also, like MB means the modifiable balloons. And then we have no other way to choose another armamentarium. So the next level is the IVL or the device-based therapy means atherectomy device. I chose the IVL this time. So this IVL, you see that 1:1 you have to take, and it's a 3.512 IVL. Initially, after 30 pulses even, still not uniform the balloon. Even the IVL balloon was not properly inflated. So not too much crack I have seen by even IVUS. Still calcium is there and need more pulses. So another 40 pulses we have, 30 pulses we have given with 4 to 6 atmospheric pressure, and now you can see the IVL balloon is also has become uniform here, and you see in the right side the cracks. It has become very much softer than it were before. So then easily it has been stented and then post dilated. And also we have seen a post PCI IVUS, and also it is good, it looks good. So happy ending with IVL. So in this case, rotablation could work as well. IVL also worked well here. Least complication with increased cost for IVL, a delicate balance from the operator's perspective. And obviously, if you could see a very horrible nodules or eccentric, very much eccentric calcifications, maybe the role of IVL would be a question there. What about this case with the left main LED lesion with severe calcification? This case is a 60-year-old patient, but very much fragile, also with class 3 angina. It's a smaller caliber radial artery, so you have to take the transulnar approach to take a 6 French guide catheter. And then you can appreciate the calcium everywhere, not only in the coronaries, but also in the structure in the valves also. So here, this severe calcification, how to deal with, because it is in the proximal LED, you see here, and quite disturbing calcification. Prediction is there to ask for spatial armamentarium to manage the might of the calcium. OCT and IVUS obviously is needed. So how we will go for this one? Only MB scan or modifiable balloons can work there, or upfront rotablation, or IVL in the distal left main LED, or you will go for the rotatripsy. So what I've done is that the meticulous vessel bed preparation we have done. Sometimes MB can crack the calcium, IVUS and OCT can ensure it, and then what we have seen in the IVUS, 260 to 360 degree calcification in both proximal and ostial extending to the distal left main, not cracked that much with the modifiable balloons. So now the question is, what should be the next move? Also for this case, debulking in the left main with the fragile patients. I was a little bit skeptical for that one. It is possible, but involving the IVL, whether it is possible or not in the distal left main to do an IVL, possible and safer, though the RCTs which has already so far done didn't include this left main subset for IVL. Yeah, but planned for IVL for this case. This is the magic one. And which diameter you have to take? 1:1, but all the time you have to remember the crossing profile of the IVL, because sometimes maybe 0.25 less than the diameter should be taken, because otherwise the balloon may not cross. So delivered the shock here, it's with a 312 IVL and 20 pulses each, both proximal and involving the distal left main and early mid LED. And then hot spots got melted like that ice. So post IVL IVUS was good and soothing, so no hiccup while taking and deploying a 334 days in left main to LED, followed by POT and followed by the IVUS re-imaging, and has shown that proper apposition of the stent. So it's quite happy with this one. This is the final peak here. So shock is feasible or possible in left main subset also. As newcomer, new trials are limited. The latest ones disrupt CAT3, and there is a registry also. And this is 384 patients only, but it has been seen that 1 year outcome is really good. And this crunch registry has expanded the IVL towards the ISL lesions, and here also it has become effective, of course, in a very small population. Like this case in the ISR, you can see that there is a stent there, and beyond the stent, just proximal to the stent, and then within the stent itself, and just distal to the stentor segment, there is a huge chunk like calcium there, and there is a tortuosity also there. So this, how I will deal these things. IVAS catheter was not crossed even, so, and with the 2.5 NC balloon, you can see that the crump in opening here, and further escalation of the balloon was not even possible with this one. So in some segments, almost 360 calcifications. Better to take an IVL for this case, and what we have done, the 30 pulses yet didn't work, and then another 40 pulses, then it has been beaten. And then post IVL IVAS, you see that how much crack has been done in that segment. So ultimately the stenting was very much beautiful here, and no other possible problems even in the final IVAS also there. So IVL seems to me like a soothing violin, to wrap up if I can tell. Unlike a atherectomy, IVL requires no specific training. The risk of atheromatous embolizations, which can be done by the rote ablation especially, this is, there is no risk for embolizations. Circumferential modification of the calcific atheroma is possible. Minimizing mechanical vascular trauma is also possible. SB protection using IVL can easily be performed using IVL. So thank you very much for your patience hearing.
Thank you for excellent presentation on case-based discussion on shock therapy for frail patient. Now may I request Professor Arun Maske. He will talk on stent fracture, missed but not uncommon.
Chairpersons, panelists, my professor, Sophia Rahman is here, my mentor and professor, and all my seniors. Thank you, Sky, for giving me this opportunity to present. After a wonderful session of complex left main, CTOs, calcified lesions, I'm going to talk on different topic, which I think is not much covered in many of the intervention sessions. My topic is stent fracture, missed but not uncommon. I'll just give you a brief overview of one case. I do not have any potential conflict of interest. So this is a 72 years old lady. She presented with chronic stable angina. Her treadmill test was positive. She had single vessel disease, LAD. She had stent, cipher stent 3x33. This was way back in May 20, 2012. Unfortunately, I cannot show you the CD because that time we had an earthquake in Nepal and she destroyed her house, and this cath lab was old, so I could not retrieve this CD. It would have been wonderful if I had that CD, but I can tell you this, the angiogram was simple long lesions, focal type A lesions. And this lady presented in October 29 with 2015 with atypical chest pain. Did an angiogram. This lady was on dual antiplatelet therapy and all guideline directed medical therapy. This is an angiogram of the patients, and what we can see here is there's a ectatic segment in the segment of LAD. If you look closely in this patient, what we can see here is a complete stent fractures, and there's a gap, but this lady has TB3 flow. So as she had only atypical chest pain, TB3 flow, decided to put on dual antiplatelet therapy. That period of time we had only aspirin and clopidogrel and other guideline directed medical therapies. And in October 12, 2014, she came with 3 hours of chest pain with anterior STEMI with acute stent thrombosis. So in the interest of time, I've shown many pictures. So she underwent primary PCI with 3x48 millimeter Giants expedition stent, and this was post-dilated adequately with 3.5 balloon, so angiographically looks good. And again in 2016, December 18, she came with 6 hours of chest pain, anterior STEMI. So what should we do? This is a second stent fractures, and if the patient coming with the stent fractures, the ideal treatment is try to open the vessels, do balloon dilatations, and send patient for surgery. Despite trying to convince patient and relatives, they said, I don't want surgery. I would rather die. Do whatever you want to do. So we don't have any choice. So, sorry. How can I play this one? So patient is in the cath lab. So this is our worker's wire. We can see a fracture stent in the mid portions. And wire was passed gently. And here is important to pass the balloons through wire and balloon through stent struts. The one technique is you pass a small balloon, 2 into 12 balloon, and see if you are in the true lumen of the stents. And once you are sure, we can dilate the stents. This is patient is in the middle of night, so there is no question of doing an IVUS and other things. And then post dilated with 2.5 millimeter of balloon. And another 3 into 48 mm Giants stent was deployed. And this was post dilated. And this is a picture of the patient. So what we can see is after stent there's a bruising in this patient. So we did not have any choice to put a stent despite the fact that the CABG would have been a better option in these patients. So this is a picture here, 3 into 48 cipher stent, fractured, put another stent, and she has 3 layers of stents here. And October 2019, she went to Australia in 2018. She had non-ST elevation MI. She came back and we did an angiogram in 2019. Distal to stents, there's areas of some tight lesions and there's a myocardial bruising. So she's not keen on doing any surgeries. So we decided to put patients on medical therapy with aspirin and clopidogrel. And I'll show you image at the end. This is a image IVUS of 3 layers. In the interest of time, I'll show you at the end. So summary of this case, 2012, she has elective PCI to LAD, cipher stent. We all know that cipher stents are prone to aneurysms. 2014, she had October 9 to 29, she had asymptomatic stent fractures, was on dual antiplatelet therapies. December 12, 2014, she came with STEMI. She did a primary PCI with Giants Expedition 3 into 48 stents. And December 18, 2016, again came with acute stent thrombosis, very late stent thrombosis with STEMI. And she refused surgery, so decided to put stents. And 2018, she had non-ST elevation MI while in Australia. And we did angiogram in 2019. This is a summary of the patients. So 6 months back, I had follow-up this patient who came for elective cholecystectomy. So she had a cholecystectomy and she's on dual antiplatelet therapy now. So if you look at the history of coronary stent fractures, the first reported coronary stent fractures was 2002 in a bare metal stent in saphenous venous graft. First case of coronary drug-eluting stent fractures was reported in 2004. So if you look at this incidence of stent fractures, different literature quotes 0.8 to 19%, and one study, OCD guided stent fractures, they have quoted up to 20%. The diagnosis you can see in fluoroscopy, CT, and with the use of imaging, IVUS and OCTs are better options. So the classification is different classifications, they have different classification. One strut fracture is type 1. If you have multiple strut fractures is 2. Complete strut fractures with no displacement is 3, and if there's displacement it's called 4. And in OCT classification, one single strut fractures pattern 1, more strut fractures with deformation is 2, with deformation is 3, and transection with or without malalignment is 4. So there are different classifications. The important predictors of stent fractures is technical fractures, like if you do over expansions with balloons or stents, then that might weaken the stents. Stent overlaps are prone to fractures because they create hinge point deformity and they lead to fractures. Longer stents are subject to high radial force, and inappropriate handling of stents before implantations, and stent techniques, because in cross technique, are more prone to fracture because we are using overdilatations in these patients. And the sirolimus eluting stents are more prone to fractures. And the important point is stent conformability. This stent conformability is the degree at which the stent bends around the longitudinal axis after deployment. If there is a decrease in stent conformability, they lead to longitudinal straightening of the vessels after stent deployment, which subject them to counter prevailing force of vessel wall, and they lead to stent fractures. And anatomical factors like tortuous, highly angulated segments, long lessons, changes in vessel after stent implantation, they create the distortion force, and chronic total occlusions are more prone to stent fractures. Among the vessels, right coronary artery and saphenous vein graft occlusions locations are more prone to fractures because this right coronary artery, they have a more dynamic contractions, and this repeated contraction, they expose strain to compression, torsion, kinking, elongation, bending, and shear force that causes fracture from mechanical factors. So what is the relation of stent fractures and thrombosis? There are many studies saying the stent thrombosis in the fracture group was higher than that in the non-stent groups. And another study says no significant difference in the stent thrombosis between stent fracture group and non-stent fracture groups. So the conclusion is stent fracture and stent thrombosis both are rare, but the relation between them is uncertain. So the conclusion is stent fracture is uncommon. Clinical presentation may be asymptomatic, recurrent angina, MI or sudden death. Right coronary lesions, stenting, lesion angulation, long stents, use of drug-eluting stents are associated with increased prevalence. Coronary angiogram is not usually sensitive. Intravascular ultrasound, stent boost, CT and OCTs are helpful. Management should be individualized. CABG is a treatment of choice if the patient has recurrent stent fractures, and in this patient, I'm not very sure how long we should continue. DAPT and definitely low dose rivaroxaban 2.5 BD would be a choice in a patient who is refusing surgery. And I'm just showing this IVUS of this patient, and distal to the stent, there's a plaque here. As we go proximally, the 3 layers of stents seems well opposed. So as we move proximally, that area is because of, I think it's because of aneurysm of vessels in LAD. As we move proximally, there are areas of malappositions and maybe some new intimal hyperplasia, intimal proliferations. Here, stent looks well opposed. I have 30 more seconds, I think. Please bear with me. This is a proximal LED. Now we are in the left vein. Thank you.
Okay, thank you very much. Our last speaker of this session is Dr. Imad Sheiban. He will talk on update on HBR, choosing stents and antiplatelet therapy.
So good morning to everybody. Today I have a challenging topic, that means the choosing of stent and antiplatelet therapy in high bleeding risk patients. We know that there are some factors associated with an increased bleeding risk after PCI, and you can see the age, renal disease, liver disease, active cancer, something related to laboratory testing, bleeding history, iatrogenic as well. And we have also factor associated with an increased ischemic event risk after PCI, like prior stent thrombosis or adequate antiplatelet therapy, stenting of the last remaining patent vessel, diffuse multivessel disease, kidney chronic disease, extensive stenting, and bifurcation, as well as total occlusion with long stents that mean more than 60 millimeters. And depth intensity and duration is related to patient, related to lesion procedure, related to stent as well. And patient comorbidities, demographics, comorbidities, and clinical manifestation, with whether it is acute coronary syndrome or chronic, coronary lesion characteristic, procedure factors, stents, and so on, should be carefully evaluated in order to balance bleeding against ischemic events with depth, and this is particularly important in high-risk bleeding patients. Of course, the first thing to do is to minimize the risk of stent failure. And we have spoken yesterday, the keys of success is keep it as simple as possible. Don't do bulky things particularly on the carinae bifurcation. Step-wise approach, even with the simple stenting. Intravascular guidance is recommended always, and lesion preparation, stenting, optimization, that means well expansion, good apposition of the stent is absolutely important. We have, in order to evaluate the risk of bleeding, we have several score systems coming from trials mainly, and the most used and recognized by guidelines is precise depth score as well as depth score. And this is show you how the risk is endorsed by guidelines is useful in for predicting bleeding events in patients with acute coronary syndromes undergoing angioplasty, as you can see in this study. Now I'll start with a clinical case. This is a clinical history of this patient, 84 years old, type D diabetes, anemia, moderate chronic renal insufficiency, peripheral artery disease, and previous gastric ulcer, bleeding, healed 8 years ago, previous inferior myocardial infarction, and then evolved in ischemic left ventricular dysfunction. Now he has ejection fraction of 0.45. In May, he was admitted for chest pain, ST depression in anterior lead, an echo posterior akinesia, anterior hypokinesia, and ejection fraction was 0.35. T-troponin increase, persistent discomfort, and the strategy, of course, in this patient is very challenging because he is a very high bleeding risk patient. So PCI is complex with severe calcification, severe distal left main lesion, and I'll show you, this is the angio, see heavily calcified left main and almost all the proximal and mid segment of LAD and diffuse disease. And of course, in this case, I think the principal thing to do is to prepare the lesion as much as possible in order to be sure that your stent will be fully expanded and fully opposed. And of course, in this situation, I think debulking by rotablation, at least by rotablation, is absolutely necessary, as well as IVUS guidance in order to reach after your procedure, to reach the most optimal result in this patient. And you can see very, very good final result with fully expanded stents and in left main and LAD, as well as distal left main bifurcation. Then optimization should be done, and this is the final result. Now, this going for the clinical data, what we have about the depth in these patients, we have here the meta-analysis coming from 5 randomized trials, and you can see that mostly at least 50% of cases included in this trial with acute coronary syndromes. Mean stent length is almost long because ranging between 25 and 40. And I would underline that variety of stents have been used in all these trials. And if you look on the outcome, you can see that there is no difference in ischemic events and shortening the depth duration. But what the most benefit is less bleeding events in these 5 randomized trials. Then more recent trials like Master Depth trial, showing again that this was with Ultimaster stent. Again, that clinical events, adverse clinical events are not changed, shortening the depth for 3 months, abbreviated that at 3 months, and what will have the benefit, the most important benefit, that we are reducing significantly bleeding in this cohort of patients. Again, from Science 90 and Science 28 studies, showing that, again, no difference in clinical events, but bleeding, major bleeding, I would say, are significantly, markedly reduced, reducing the duration of depth from 6 to 3 months. And if we look also further data from the same studies, Science 28 and 90, coming to only 1 month, this will have the same outcome. That means reducing ischemic events, reducing bleeding events without any change in ischemic events. The Evolve short depth study done with the Synergy stent, again, one of the stents mostly used today in our clinical practice, and showing again no difference between in clinical outcome, that death and myocardial infarction in between 3 and 15 months, while the stent related ST segment, that means stent thrombosis, is not changed, and the bleeding events are reduced. Now, again, this is another very recent study showing that the de-escalation and short dual antiplatelet therapy, there is no difference in the 2 modes of abbreviating the depth, no difference. The only difference that with the short depth, will reduce bleeding events more than the de-escalation, while de-escalation might slightly reduce clinical events as compared to short depth. Which stent? Here is two editorial by Capodanno analyzing all the studies done with short depth, and this show that most of contemporary stent were included in this study, and all of this study was showing that reducing the duration of depth will reduce bleeding, but will not affect the efficacy in all whatever stent we are using. Will be the same result. Now, again, this coming from how to do it. I mean, to summarize what is coming from trials. Again, starting from clinical judgment, then the first step is risk classification, with then depends on complexity of the procedure, the risk scores, genetic testing, and platelet function testing sometimes are required and could be done. After this, patient will be classified as high bleeding risk, low bleeding risk, and low bleeding with high ischemic risk, as well as low bleeding risk with low ischemic risk. In this category, that means the middle one, this is the most simple. Why we can keep the standard duration, that means at least 6 to 9 months in depth, while in the other, that means in this side, that high bleeding risk with regardless of ischemic event should be shortened, and this will not affect, reduce the bleeding, but without affecting the outcome. Again, the shortening the antithrombotic therapy will this is show globally that will reduce a bleeding event, and will not affect the outcome of the procedure in terms of ischemic events. This is in acute coronary syndromes as well as in chronic coronary syndromes. The same result will be obtained. The only difference that in acute coronary syndromes, if it is the bleeding risk is low, then duration of depth should be extended to 12 months. And the most used scores are precise depth score and depth score. And you see here that these with the simple, easy, and rapidly available can give you the possibility to classify, to locate the patient, and to do your procedure and the depth after accordingly. This is coming from the most recent guidelines of American Society of Cardiology, and I would say that respecting what we have seen from the trials I mentioned before, and this is the summary of guidelines that mean including American College of Cardiology, American Heart Association, and the European Society of Cardiology in stable and chronic ischemia. Then there is no high bleeding risk, no any change. That means 6-month duration should be kept, while in high bleeding risk, this can be shortened safely. We have more support by European guidelines for 1 month rather than the American College of American Heart Association, American College of Cardiology guidelines. And in acute coronary syndromes, you can see that in no high risk for bleeding should be maintained, the depth maintained until 12 months. Some is suggesting to even prolong to 30 to 30 months, but this is not well supported by clinical data. In high bleeding risk, again, the shortening, but we still not in class 1A. Now, my take-home message is that in high bleeding risk patients, procedural optimization is the first step to reduce ischemic events and to predispose for a short DAPT. Evolution of stent technology plays an important role in shortening DAPT duration. Short DAPT duration, 1 to 3 months, have been proven to be effective in reduction of major bleeding without an increase in ischemic events as compared to long DAPT. And almost all contemporary stents used in daily clinical practice can be safely used with the short DAPT. Thank you very much for your attention.
Thank you, Dr. Imad Sheiban, for your excellent presentation. I would now like to conclude this session. I would like to thank all the speakers for their excellent talk, the chairperson, the panelists, and the moderators. Now, if there is any question, I think there's one question from my
I know time is up, but I have only single question to Professor Gambhir. Thank you very much, sir, for your masterly presentation. My question is that if a patient with ACS, maybe STMI or non-STMI, presented with cardiogenic shock, and you got the patient, the left main is 100% occluded, what will be your approach, or what guideline says in this context? Cardiogenic shock, left main is 100% occluded. There is no mechanical support in the cath lab.
Well, I think the first thing is that if a patient is a hypotensive, he's in cardiogenic shock, and you don't have any mechanical support, I don't think the patient should be taken to the cath lab. Should not be taken. It's a waste of money.
The patient is only in the cath lab, angiography is done, left main is 100% occluded, RC is normal. Then what will you do?
No, in that case, certainly the first attempt should be, if the patient has got a borderline blood pressure, you attempt to raise his blood pressure by inotropes. Try to bring it around 80, 90. The first thing you should do is to recannulate and try to achieve some flow in the LAD. Because by just restoring flow in the LAD or in a dominant circumflex, as I showed in my first case, the patient's blood pressure starts improving even without a IABP support. So that must be tried. And if you can sustain that flow for some time, then you just stent whatever vessel comes across, whether it's LAD or circumflex, provided the circumflex is dominant. By stenting, you sustain the flow. And then you can work upon the other side of the coronary tree, that is LAD or circumflex. And God willing, you should be able to bring the patient out of the cath lab without even IABP support.
I would just like to add here, since the patient is already on the cath table and he's done an angio, there's no harm trying to do some form of revascularization. I would
like my first case, we didn't put him on IABP support.
Yeah, no.
People did say, but as soon as I wired the circumflex and did some thrombosection, the flow started in the circumflex and patient's BP improved to about 80, 90, 90, 100. We kept on working, but it again occluded. So we then stented the circumflex and then went on to do the LAD. But no IVP was required.
So would you like to say anything to conclude the session, Professor Gambhir?
Well, I think at the end, I must say that all the speakers have done a good job, but only thing I wish there could have been some more points of discussion. We are not leaving points for discussion. And I'm sure there are people in the audience who have several issues, queries in their mind. I had several issues, but since time did not permit us for having discussion, so we have to really keep quiet and just keep on listening to the speaker. So when we make a program, 2-3 minutes of discussion is mandatory to keep the audience active on their heels and let them remain awake.
Thank you.
Thank you very much, honorable chairpersons, moderators, and the panelists for the brilliant Cto intervention session. Now the moment to give away session. For this purpose, may I request Dr. Rehan Anis to hand over the crest to Dr. Saidur Rahman Khan. May I request Professor Saidur Rahman Khan to hand over the crest to Professor MD Mamunur Rashid Caesar. Professor MD Mamunur Rashid Caesar to give away the crest to Professor Arun Maski. Thank you very much, dear colleagues of home and abroad.